Thanks, Dan and Dana, for the invitation. Thanks to Sages for putting on this course. I'm going to change gears a little bit here. My task was to talk about emerging technologies, approved and investigational procedures, and I logically kind of went to the area of the space where things are really evolving now, and that's the endoluminal space. I'll start. I didn't put any slides in it, but just to start, the ASMBS does have a process to look at new procedures and new devices, really vet them based on the current evidence and decide. Essentially a task force is formed and evidence is looked at, pro and con decisions arguments are made, and the task force essentially decides, is this ready for prime time or not? It's a little bit different process when something goes through the FDA and already reaches that level of scrutiny. But the ASMBS as a group really wants to put things out on a most conservative approach, and we want to see the evidence there to support the safety and efficacy of the things that we endorse. So anyway, with that preamble, I'm going to jump into a fairly rapid whirlwind tour of the endoluminal space here. I don't have any relevant disclosures regarding this presentation. And we want to gain familiarity with some of the current endoscopic devices and procedures for the treatment of obesity and diabetes. We'll talk a little bit about balloons, which you're all familiar with, and then talk about some of the newer endoluminal gastroplasty procedures and some of the endoluminal barrier and mucosal resurfacing procedures that are coming out. So it's really nice now to have some more tools in the toolbox to fill this gap between medical and surgical therapy. For the longest time, there was really nothing there, and what was there was really on the fringe, and now we've gotten things into our practices that we can offer patients that don't want surgery and aren't effectively treated with medical therapy. And of course, as you know, all of these endoluminal therapies are really targeting, in large part, portions of the gastric bypass or some of the surgical procedures that we do, whether it's volume reduction of the stomach or delivering nutrients or impairing that nutrient bile acid interaction in the foregut or sending things downstream quicker. All these things we know play a role in the bypass physiology and are essentially being mimicked by some of these therapies. I'll start with the balloons. How many in the audience are putting balloons in? Probably about 40%, 50%, good, okay. So it's out there. Surgeons and GI physicians are actively pursuing this as an option for their patients. There's 2 FDA-approved balloons on the market right now. I don't have an interest in either one financially, so I'll talk about both of them separately. They're very easy to put in. It's an endoscopic procedure under deep sedation at most, and inflate the balloon and take a look at it and make sure it's where it's supposed to be. It takes about 10 minutes to put it in and about the same to take it out. You go down, you puncture the balloon, you drag out the shell of the balloon. And so from a procedural standpoint, it's a very straightforward, easy thing to do. I think the challenge is picking the right patients and offering it to the patients who have reasonable expectations in which there's no contraindications to doing this. The Orbera balloon has undergone its pivotal trial. It's FDA approved, and it is out there being put in on a daily basis. The trial really targeted BMI between 30 and 40, randomized to a treatment arm or a control arm that received behavioral therapy only. The balloons were in for 6 months, and those patients were followed for the remaining 6 months as a follow-on. So Orbera patients had a mean excess weight loss of 38%. And lost significantly more than the control arm, and maintained their weight loss over the control arm during that follow-on 6 months after the balloon was out. The Reshape Balloon is just a little bit different technology. I don't know if this video is going to play. Probably not. Anyway, we'll the Reshape Balloon is really a dumbbell-shaped balloon that is intended to create the same space-occupying device within the stomach lumen, but it has a dual balloon technology so that if one should deflate, you have the less chance of migration of the shell. This is their pivotal trial. It's called the REDUCE trial, led by Jaime Ponce, and you can see the algorithm as patients completed their treatment or their control therapy. And what you see here is either through an intent to treat or completed cases that a fairly high number, around half of the patients, met the proportion of excess weight loss that was the endpoint, which was 25% excess weight loss. And they had improvements in quality of life across most of the domains compared to the control group. And this is something I show my patients who are going to get a balloon, because that first week or two can be fairly miserable. And fortunately, after the first week or two, those symptoms of pain and nausea dissipate and patients can resume a fairly normal life, but you have to prepare them for this initial onslaught of pain and spasm and nausea. And there's this meta-analysis that really looks at a wide variety of study designs, but essentially looking at the balloon compared to mostly behavioral therapy. And you can see that the forest plot demonstrates clearly favors the outcomes in balloons over whatever comparison group, whether it was a sham or a behavioral control group. And again, in this meta-analysis, you can see that the intervention group, which were the balloons, had significantly more GI-related symptoms, but again, these are fairly short-lived. So that's the balloon, and the ASMBS has put a guideline out, a position statement endorsing the balloon as an option for treatment of obesity and metabolic syndrome. And we emphasize it be done within the setting of a multidisciplinary treatment team and not done purely as a procedure alone, and that it be done as part of the armamentarium of the obesity treatment team. I'll move to stapling and suturing. There's lots of things that have been tried. You're probably maybe familiar with the satiety product Toga, which was an endoluminal stapling device. That went through its pivotal trial but did not get FDA approval, was never pushed through as an approved device for mainly safety reasons, but it's the closest thing to surgery that was done through the endoscope for quite some time. Endoluminal suturing has come in various forms over the years. Some of the initial work done in Venezuela tried to essentially approximate the anterior and posterior walls of the stomach with a suction-based device. Chris Thompson and our group worked together to try to mimic that data. We're unable to demonstrate the same efficacy using this device, and then the important thing, and this was the device at the time that we were using, and that's the pattern of sutures that we placed, really to create an endoluminal sleeve gastroplasty. The challenge with this is that number one, we weren't getting robust bites, and I think some of those barriers have been overcome with the current technology. But like any of these therapies, what you'll see when the data comes out is you'll have a group of responders and you'll have a group of non-responders. And when you look at the excess weight loss overall, 30% sounds pretty good at 12 months, but there was wide variability in how patients responded to this. They liked it. They went home the same day. They had some feeling of early satiety and satiation, but it dissipated over time as the plications came apart. But you can see here half the patients responded well, 30% excess weight loss at 12 months, and the rest went on to need something else. So the current technology is really a different pattern rather than the anterior to posterior plications, which tend to disrupt. Two things associated with this technology is deeper bites that are more surgical in nature, similar to what we would use with our EndoStitch device in the operating room. And no idea why the screen is flickering, but that's a different pattern of plication, and it's deeper bites. And so the idea here is to really plicate down that greater curvature. And some of the initial data, you can see here how the end result looks endoscopically and on an upper GI. You're really plicating in that fundus to decrease that fundic receptive relaxation. And it can be done safely. You do get pain and nausea with this too. And 22 completers at 1 year, you can see the initial BMIs dropped by about 7 points in this initial study, with the average percent weight loss of 18%, which is certainly clinically significant weight loss. Other devices, and so in terms of that Apollo device, it's under trials, it's under investigation, people are using it. It's not something that has an FDA indication at this point, and it's not something ASMBS has come out and endorsed as a approved procedure, because we're awaiting that pivotal trial with that device. The POSE study is a different device. USGI made this plication device that really creates a pleat of stomach. And again, the idea is to pleat down the fundus and decrease relaxation of the fundus with meals. There was an initial trial done overseas in Spain with 147 patients that was done safely with 1 year results and a total weight loss of 16 kilograms, which equated to about 15% total weight loss, which again is clinically significant weight loss. It's somewhere in between medical therapy and surgery. And I think that's really the playing field that we should be thinking about when we talk about endoluminal therapies. It is currently completed a pivotal trial with 377 patients in 10 centers. And as we typically see with these devices, when you put them in the hands of a variety of different surgeons and endoscopists, you get more variability in results. So this was a treatment to sham-controlled randomized trial. All patients received behavioral therapy with an endpoint of a higher percentage of patients getting treatment achieving 5% total weight loss. And they looked at quality of life as well. Can be done fairly short period of time. An average of about 13 of these little anchors, these little pleats were placed along the fundus, and you got about 5% weight loss in the treatment arm compared to 1.5% in the control group. The response rates were achieving that 5% weight loss, 40% of the treatment group, 22% in the sham group. So this did not meet the primary endpoints for the FDA pivotal trial, although they were able to show some positive results with symptoms and quality of life and very few adverse events. So it remains to be seen whether this will be FDA approved and move forward into our armamentarium or if not. So again, this is not something that has entered any of our guidelines in terms of an approved procedure. Moving into barrier devices, there are a lot of things, again, that have been tried over the years in various iterations that are continuing to be tried. The thing that got the most traction was the Duodenal-jejunal liner, the EndoBarrier device. This is unique in that it has a unique mechanism and really went from treating obesity to focusing on the treatment of diabetes, which I think makes it unique in this space. And it really targets the separation of that bile acid duodenal mucosa interaction with nutrients in the foregut, which mimics that bypass part of our operation. And it's placed endoscopically. There's a delivery system. We were part of the trial, the FDA trial. It's a pretty straightforward thing to put in. Safe, but those bidirectional barbs that you put in the duodenal bulb can cause pain, spasm, and bleeding, and turned out that was probably the Achilles heel of this device because you probably got some bacterial translocation from this anchoring system that resulted in some hepatic abscesses, and that's where the FDA trial stopped. But when you look back at the data, it was initially used for obesity, small numbers, but excess weight loss of 42% or 18% total weight loss. But you can see there's some dropout here. There's the completers. Completers are what's in the analysis, but patients do want these things out sometimes because of pain or complications. And when you take the device out, of course, you get recidivism or recurrent weight, but at 6 months after the device was removed, most of these patients had about 75% of that weight loss was still in place, and so there's a bit of a lag in terms of weight regain. And importantly, you're treating diabetes with this device, you get a much higher improvement in control, which is A1C less than 7, both in the completer and the last observation carried forward analysis in some of these diabetes studies. And when you look at the diabetes effect after the device is removed, you do get that legacy effect with this, and so you do change the trajectory of the disease. And while we know it's going to recur over time, you have altered the overall path of that progressive disease. And you can repeat therapy, and I think that may be a paradigm for all of these endoscopic therapies of repeatability, revisability, moving on to the next step. But in this particular study, 8 patients, but they were all able to, with reimplantation of the device, achieve that same nadir of their weight loss again. And importantly, this is one of the few things in endoluminal space that has a mechanism. Small study of 17 patients and measured at both early post-op and at 24 weeks after the therapy, but anti-diabetic medications were reduced significantly, and a glucose meal response was improved both at 1 and 24 weeks, and area under the curve improved compared to baseline. But importantly, by excluding that nutrient and duodenal interaction, we're getting some of these same effects that we see with the sleeve gastrectomy and the gastric bypass. There was an early and sustained elevation of GLP-1 and PYY in these patients. So you're somehow stimulating those L cells, whether it's by a neurohumoral mechanism or just delivery of contents more distally. And I think this is important when you talk about some of these devices. The early safety data was great. After they went through several iterations of the anchoring system, there were very few complications. The problem arose during our pivotal trial that was moving along and had enrolled about 225 patients, but 7 patients developed hepatic abscesses, and the study was halted. And currently, the company and the investigators are working through this issue to try to see if this is something that we can move forward with. Because I think this is one thing. When you talk to endocrinologists, they like this device. It fits well within their idea of what's good endoscopic treatment. It's not surgery, and they like the fact that it has a mechanism. So this, I think, still holds promise. I think there's some things that need to get worked out. I'll end with a couple of things that are not that are still clearly investigational. The transpyloric shuttle is an endoscopically placed ball valve, essentially, that's put in and transits the pylorus, as you can see here, and essentially creates an intermittent gastric outlet obstruction with peristalsis that results in early satiety and delay of gastric emptying. This study is undergoing enrollment for its pivotal trial with a primary endpoint of 5% weight loss in the treatment group over the sham group. And so they're currently enrolling 222 patients with, again, a lower BMI indication. So more to follow on that. And finally, the Revita procedure is again, it targets this duodenal mucosal interaction. And this is a thermal ablation of the duodenal mucosa. And you can see on the left, pre-treatment, during the treatment in the middle, and post-treatment, you know, even though you're just ablating mucosa, you do get some atrophy or some changes in the mucosal surfacing with the ablation. And this is a first-in-human trial looking at this. There were two groups of patients. Some had a short segment of 3 centimeters treated. Others had a 9-centimeter segment treated. What they found was that there was an overall reduction of 1.2% at 6 months of A1C. But there was a dose response here. So it seems like the longer segment you ablate, the more improvement you get in your A1C. With a 2.5% reduction in the 9-centimeter group versus 1.5% in the short segment group. And so this is still obviously investigational. And there were a couple of strictures that required dilation. So this is a concept that I think holds promise, but again, it needs to be worked out more thoroughly in terms of long-term safety. Aspire Assist, this is an FDA-approved device. It's a G-tube that's placed to allow patients to evacuate about 30% of their ingested meal. It's hooked to a pump, and they go to the restroom and they evacuate their stomach contents after their meal. You can have a lot of debate around the philosophy behind this, whether it's something that fits with our model of treatment. But the fact is it's FDA approved, and their initial FDA and early studies demonstrated really good weight loss at 50% out to 2 years, which is significant weight loss. So the question is, can this fit into a paradigm that we can all embrace, or is this something that is really outside of what we would consider acceptable sorts of treatment for our patients? I don't have the answer to that. The ASMBS has not stepped in and made any statements about Aspire, and don't plan to. I think that we have to let this sort of work itself out in the marketplace a little bit, but it is FDA approved and is available if people are interested in this particular device. So in conclusion, we have less invasive options. There's more and more emerging all the time. Most of these results are short-term, and there's partially a reason for that. Most of these things are removable or temporary therapy, and so we have to start thinking about repeatability and repeated therapy. There's less risk but generally less effectiveness with these procedures and devices. Balloons are here, but I don't think clearly understand where they're going to fit into our overall treatment algorithm yet. And there's some promising concepts being studied, particularly around the duodenal exclusion devices. And this all may be part of what we start developing as a multimodal therapy treatment plan, which is medication, behavioral therapy, and some sort of endoluminal procedure as well. Thank you very much, and I would invite anybody who wants to hear more about these or come to a course. ASMBS Weekend is in San Diego in June. And as Phil mentioned, we have Obesity Week, ASMBS National Meeting in DC this November. Thank you very much.